used the nutrient fiber plus lactobacillus. And as you see in this rat experiment, we got sepsis in 21 or 24 animals where we ligated the cecum and made a hole on it so that the content could come out into the peritoneum and infect the whole peritoneum. In that group, 21 or 24 got severe sepsis. If we treated with extensive antibiotics corresponding to the treatment of selective decontamination, it was 8 of 24 who got sepsis, but generalized sepsis, and if we treated with lactobacilli, it was not much different, showing that we could replace expensive and eventually dangerous antibiotic treatments with a safe and inexpensive lactobacillus treatment. We have then performed a lot of studies in healthy individuals, tolerance studies, having students to live for long periods of time on the solution, establishment studies, having persons to drink the solution, stop to drink, and then take biopsies from the colon regularly each week to see how long the bacteria stay and work, etc. And it's a tedious procedure before any new substrate, any new solution, any new drug can be used in patients regularly. So this is not done. But we have seen 5 patients dying from multi-organ failure where we could not resist to use the new treatment. This group of multi-organ failure has usually a mortality of 80%. 1 out of 5 will eventually survive, 4 will die. And those working with intensive care know this very well. And I will go into detail with 3 of the patients. This is a man who was operated for perforated duodenal ulcer. A simple operation, but things went wrong. 3 laparotomies followed. Severe sepsis, progressive multi-organ failure. You have seen that, all of you, many times. We agreed with the intensive care doctors and with the anesthetists and other colleagues at the hospital in Lund to discontinue all antibiotics. You know, the patient was so bad that everyone said, well, they do not do well anymore. We can't help the patient anymore. The patient was fed with large quantities of lactobacilla and fiber. There was a dramatic improvement, and the patient could leave the intensive care. This woman, 63, had an ischemic colitis, and a subtotal colectomy was performed. She developed abdominal abscesses, small bowel fistulas, and a gangrenous ileostomy. Several operations, generalized sepsis, even fungi, and respiratory and renal insufficiency. Again, all antibiotics were discontinued. Large quantities of lactobacilla and fiber were given through the most distal enteral fistula. And we saw a gradual improvement, and the gastrointestinal canal could be restored after 1 month, and the patient could leave the hospital. This man, 74, had a GI bleeding, gastrostomy, rebleeding, had a necrotic myocurvature, and a relaparotomy was performed. A gastric resection was done, gastrostomy. The stomach was resected and the esophagus was drained to the air. So there was no continuity to the intestine. And a nutritive urinostomy was performed. Patient developed gangrenous cholecystitis, relaparotomy, continued to deteriorate, multi-organ failure. Now the patient was losing territory, and we decided to discontinue all antibiotics and feed enterally, as in the 2 other cases. a gradual improvement, and after 2 months we could restore the gastrointestinal canal and the patient could leave. Well, this then became a problem for Bengt Jeppsson and myself. This is fine, you know, but this is only case reports. Can you document this in an objective way? And we then decided to go to the Apache score. You know, there are described in the literature something called the Apache score, which is for trauma, which is to describe the severity of disease in severe patients. It's based on a lot of criteria, function of the vital organs. And here is the Apache scores for 14 days in a patient in intensive care. And then the treatment is introduced, and here you can see